Hello, friends. Today we are going to discuss about the 2021 guidelines of acute heart failure. And in this, we are mainly discussing with the heart failure with mildly reduced and preserved ejection fraction and advanced heart. So first is angiotensin converting enzyme inhibitor. There are no specific trials of AC1 inhibitor in patient with the heart failure with mildly reduced ejection fraction. Although the PEP-CHF trial was conducted in patient with heart failure with preserved ejection fraction and included patient with ejection fraction of more than 40%, it did not report the outcome according to the higher ejection fraction. However, in patient with heart failure with mildly reduced fraction, many will also have this coronary artery disease, hypertension, and post-MI LV systolic dysfunction, and will therefore already be treated with the AC inhibitor. Therefore, AC inhibitor used may be considered in patient with heart failure with mildly reduced ejection fraction. And then angiotensin receptor 2 type 1 receptor blocker. There are no specific trials of ARB in heart failure with mildly reduced ejection fraction. The CHAN preserve trial missed its primary endpoint of CV death in heart failure hospitalizations. However, a retrospective analysis showed that candesartan reduced the number of patients hospitalized for heart failure among those with heart failure with mildly reduced ejection fraction. Moreover, a recurrent event analysis suggested a reduction in hospitalization for heart failure among the entire CHAM preserved cohort, including those with heart failure with mildly reduced ejection fraction. As for ACE1, many with the heart failure with mildly reduced ejection fraction will already be on the ARB for another cardiovascular indication. Therefore, treatment with the ARBs may be considered in patients with the heart failure with mildly reduced ejection fraction. Regarding beta blocker, there is no specific trial of beta blocker in heart failure with mildly reduced ejection fraction. An IPD meta-analysis of landmark trial of beta blocker suggested a similar reduction in cardiovascular and all-cause mortality for patients with sinus rhythm and heart failure with reduced ejection fraction and heart failure with mild reduced ejection fraction. This IPD meta-analysis included seniors trial where nebivolol reduces composite primary endpoint of all-cause mortality and cardiovascular hospital admission in overall population. No interaction between ejection fraction and the effect of nebivolol on primary outcome was observed. Many patients with heart failure with mild reduced ejection fraction may have another cardiovascular indication, such as atrial fibrillation or angina for beta blocker. Therefore, treatment with the beta blocker may be considered in patients with the heart failure with mildly reduced ejection fraction. Mineralocorticoid receptor antagonist. There is no specific trial of mineralocorticoid receptor antagonist in heart failure with mildly reduced ejection fraction. In retrospective analysis of TOPCAT trial in patients with ejection fraction of more than 45%, spironolactone reduced the hospitalization for heart failure in those with ejection fraction less than 55%. Then the next is RNA receptor inhibitor. There is no specific trial of RNA in heart failure with mildly reduced ejection fraction. In Paragon heart failure trial, which included patients with the ejection fraction more than or equal to 45%, although the trial missed its primary endpoint overall and a significant ejection fraction by treatment interaction was observed. Sacubitril valsartan compared with the valsartan reduce the likelihood of primary composite outcome of uh, CV death and total heart failure hospitalization by 22% in those with ejection fraction below or equal to median of 57%. Further data are available from combined analysis of paradigm heart failure and Paragon heart failure trial showing that sacubitril valsartan compared to other form of RAS blockage has beneficial effect, especially on hospitalizations for heart failure in those with heart failure with mildly reduced ejection fraction. Other drugs in the DIG trial for those with heart failure with mild reduced ejection fraction in sinus rhythm, there was trend to fewer hospitalization for heart failure in those assigned to digoxin, but no reduction in mortality and trend to excess of CV death. Therefore, there is insufficient data to recommend its use. There are also insufficient data on ivabradine in heart failure with mildly reduced ejection fraction to draw any conclusion. Devices. The while post-hoc analysis of landmark CRT trial suggests that CRT may benefit patients with ejection fraction of more than 35%. Trials of CRT for heart failure with mildly reduced ejection fraction were abandoned due to poor recruitment. There are no substantial trial of ICD for primary prevention of ventricular arrhythmias for heart failure with mild reduced ejection fraction. Trial conducted more than 20 years ago suggests no benefit from ICD implantation for secondary prevention of ventricular arrhythmia for heart failure with mild reduced ejection fraction. Therefore, there is insufficient evidence to advise CRT or ICD therapy in patient with heart failure with mildly reduced ejection fraction. In patient with ejection fraction of more than 40%, implantation of inter-arterial shunt device was found to be safe, and this device is subject to investigation in larger study before any recommendation on their use in heart failure with preserved ejection fraction and heart failure with mildly reduced ejection fraction can be given. So pharmacological treatment to be considered in patient with heart failure with mildly reduced ejection fraction. Diuretics are recommended in patient with congestion and heart failure with mildly reduced ejection fraction in order to elevate symptoms and signs. Class of recommendation 1, level of evidence C. ACE1 may be considered for patients with heart failure with mild reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. ARB may be considered for patients with heart failure with mild reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. Beta blocker may be considered for this patient, and MRA may be considered for this patient to reduce the overall hospitalization and death. And sacubitril valsartan may also be considered. And all these drugs have, except diuretic, has class 2B recommendation with level of uh, class of and for all this treatment class of recommendation to be level of instead level of and the level is C. Level of evidence is C. Now, heart failure with preserved ejection fraction. Moreover, the ejection fraction cutoff to define normal will be like higher than 50%, and the presence of high ejection fraction, that is above 65 to 70%, should prompt a search of pathology such as cardiac amyloidosis, hypertrophic cardiomyopathy, where supranormal ejection fraction may result from shrinkage of LV and diastolic volume. So the clinical characteristic of this patient is heart failure with preserved ejection fraction differed from reduced ejection fraction and mildly reduced ejection fraction in that preserved ejection fraction patients are older and more often female. Atrial fibrillation, CKD, and non-cardiovascular comorbidities are more common in patients with heart failure with preserved ejection fraction than those with reduced ejection fraction. Red flags for the potential presence of coronary artery include low normal BP in patient with history of hypertension, intolerance to beta blocker, AC inhibitor, history of bilateral carpal tunnel syndrome, low voltage on ECG, echocardiographic features such as thickened septum, posterior wall, RV wall, enlarged atria, small pericardial effusion, valve thickening. Furthermore, it is important to exclude other conditions that mimic heart failure with preserved ejection fraction syndrome, like lung disease, anemia, obesity, and decondition. So, for more comprehensive overview, we'll see that. So, the diagnosis of heart failure with preserved ejection fraction remains challenging, and several diagnostic criteria have been proposed by societies and clinical trials. The criteria may vary widely, their sensitivities and specificity. More recently, the two-score-based algorithm, that is H2FPEF and HFA-PEFFA, has been proposed to aid the diagnosis. So we'll see what is the score. H2 is heavy and hypertensive, that is body mass index more than 30, and hypertensive means 2 or more antihypertensive medicine. If body mass index is more than 30, it carries 2 points, and if the patient is hypertensive, it carries 1 point. F is atrial fibrillation. If paroxysmal or persistent, 3 point. Then pulmonary hypertension, Doppler echocardiographic estimate of pulmonary artery systolic pressure more than 35 mg, 1 point. If age is more than 60 years, 1 point. E by E prime more than 9, then 1 point. So the total of this score is 0 to 9. Now, the diagnosis of heart failure with preserved ejection fraction. The diagnosis should include following symptoms and signs of heart failure, ejection fraction more than 50%, objective evidence of cardiac structural functional abnormality, consistent with presence of LV diastolic function, raised LV feeding pressure, including raised natriuretic peptide. So these are the objective evidence of cardiac structural, functional, and serological abnormalities consistent with the presence of left ventricular diastolic dysfunction. According to that, LV mass index is more than 95 for female and more than 115 for male. Relative wall thickness is more than 0.42. LA volume index is more than 34. E by E ratio at rest is more than 9. And NT-proBNP more than 125. And PA systolic and TR velocity at rest is more than 35. So the absence of recommendation regarding disease-modifying therapies, the treatment should be aimed at reducing symptom of congestion. Loop with diuretics. Loop diuretics are preferred, although thiazide diuretics may be useful for managing hypertension. Reducing body weight in obese patients and increasing exercise may further improve symptom and exercise capacity and should therefore be considered in appropriate patients. It is important to identify and treat the underlying risk factor, etiology, and coexisting comorbidities. Undoubtedly, the treatment of some underlying phenotype of heart failure with preserved ejection fraction syndrome lead to improved outcome. So risk factor for development of heart failure is sedentary habit, cigarette smoking, obesity, excessive alcohol use, influenza, microbes like Trypanosoma cruzi, streptococci, cardiotoxic drugs, chest radiation, hypertension, dyslipidemia, diabetes mellitus, and CAD. Now, the recommendation for primary prevention, treatment of hypertension is recommended to prevent or delay onset of heart failure. Treatment with statin is recommended in patients with high-risk cardiovascular disease. SGLT2 inhibitor are recommended in patients with diabetes at high risk of cardiovascular disease. Counseling against the sedentary habit, obesity, cigarette smoking, alcohol abuse is recommended to prevent and delay the onset of heart failure. Recommendation for treatment with heart failure with preserved ejection fraction. Screening for treatment of etiologies of cardiovascular, non-cardiovascular comorbidities is recommended. It has a class of recommendation 1, level of evidence C. Diuretics are recommended in congested patients with heart failure with preserved ejection fraction. Class of recommendation 1, level of evidence C. Then regarding advanced heart failure, criteria for definition of advanced heart failure is severe and persistent symptom of heart failure. Severe cardiac dysfunction defined by at least one of the following. That is ejection fraction less than 30%, isolated RV failure, non-operable severe valve abnormalities, non-operable severe congenital abnormalities, persistent high BNP and pro-BNP values, severe LV diastolic dysfunction and structural abnormalities, episode of pulmonary and systemic congestion requiring high dose of diuretic, episode of low output requiring inotrope or vasoactive drugs, and malignant arrhythmias causing more than one unplanned visit, severe impairment of exercise capacity with inability to exercise or low distance. Pharmacology regarding management, pharmacological therapy and renal replacement. Inotrope may improve the hemodynamic parameter, reducing congestion, augmenting cardiac output, aiding peripheral perfusion. Although not proven, this may help to prevent worsening end organ function. Conversely, the traditional inotrope may favor myocardial ischemia, tachyarrhythmia, and worsen the clinical course. They can be used as palliative therapy for relief of symptom in patients without other treatment options. Intermittent long-term use of inotrope may be considered in outpatient to improve functional class and quality of life. Kidney dysfunction and loop diuretic resistance often characterize the clinical course of the patient with advanced heart failure. Doubling of the loop diuretic dose is proposed in the first instance, followed by concomitant administration of thiazide and metronidazole. In patients who fail to respond diuretic-based strategies, renal replacement should be considered. Ultrafiltration is one of the most common approaches. Then regarding mechanical circulatory device, short-term mechanical circulatory support. Short-term mechanical circulatory devices are indicated towards the critical end organ hypoperfusion and hypoxia. They can be used for short, limited period of time, from few days to several weeks. The aim is to support central nervous system, organ perfusion, to reverse acidosis, multi-organ failure until the patient's outcome become clearer, be that of the cardiac recovery, transition to durable MCS or cardiac transplantation, or in some cases towards more palliative approach. A care of patient on short-term MCS is complex and require dedicated expertise, including having specific plan for stopping support when neither cardiac nor brain injury recurs. Short-term MCS should be used in patients with intermag profile 1 or 2 as a bridge to decision, bridge to recovery, bridge to bridge for either long-term MCS or urgent heart transplantation. Long-term mechanical support. Long-term mechanical support is indicated in selected patients where MT is insufficient, or when short-term mechanical circulatory device has not led to cardiac recovery, clinical improvement, prolonged life, improve quality of life, and to keep patient alive until transplantation. So this is the schematic representation of the patient with the management of the patient with advanced heart failure. So those who have very limited life expectancy, poor quality of life, and worsen prognosis. If the answer of this question is no, then again we need to divide the patient into two categories, that is NYHA class 2 and NYHA class 3 and 4. If the patient falls in NYHA class 2 and with any of the characteristic, that is more than one admission and unplanned visit to heart failure clinic within the last 12 months, prior inotropic use, intolerance to beta blocker, RNI, ejection fraction less than 20%, worsening RV failure, worsening renal function, worsening liver failure, ventricular arrhythmias, need for escalating diuretic dose, and systolic blood pressure less than 90. Then we need to, if the answer of any of this question is no, then we need to manage to local heart failure service center and reevaluate. If answer of any of this question is yes, then we need to refer it with the advanced heart failure center. If the patient falls in the category of NYHA class 3 and 4 despite optimal medical therapy, then refer the patient to advanced heart failure center. If the patient has very limited life expectancy, poor quality of life, then opt for palliative care. Now, the patient which are potentially eligible for implantation of left ventricular assist device, those who have left ejection fraction of less than 25%, unable to exercise for heart failure, and if able to perform cardiopulmonary exercise testing with peak VO2 of less than 12 or less than 50%, more than 3%, more than 3 heart failure hospitalization in previous 12 months without obvious precipitating cause, dependence on IV inotropic therapy and temporary MCs, progressive end organ dysfunction due to reduced perfusion, not to inadequate low ventricular filling pressure. Now, recommendation for the treatment of patient with advanced heart failure. Patient being considered for long-term MCs must have good compliance, appropriate capacity for device handling, and psychological support. Heart transplantation is recommended for patients with advanced heart failure, refractory to medical device therapy, who do not have absolute contraindication. These two statement has class of recommendation 1, level of evidence C. Long-term MCA should be considered in patient with advanced heart failure despite optimal medical and device therapy, not